Hello, my name is Tom Dickey. I'm Head of Podiatry at the Leeds Teaching Hospitals Trust, and I am doing this talk regarding diabetic foot assessments. This is a whistle-stop tour, so please don't substitute this for the practical element of assessing somebody with a diabetic foot problem. This is really aimed at anybody with diabetes, from a healthcare professional to a GP to actually the carer themselves or relative. Through this, we're going to look at some assessment techniques that we use in clinic and can be used anywhere that you see a diabetic patient. We're going to be looking through the pulses or circulation, what deformity and callus looks like, infection status, risk assessment, some advice that you can look at and give, and how to refer. Please be aware that this needs to be part of a risk assessment that is actioned with an output to act upon. So we will look at risk status of patients with diabetes and feet, and these will be low, medium, high, or acute or actual ulceration. And we need to act upon each of these risk factors, which I will go through later. So this is a very practical element of looking at a patient with diabetes and feet, where we look at what is normal. So when we are looking at circulation, we can look at circulation, which is foot pulses, which we'll be going through on the next slide. We will look at how we look at sensation or lack of sensation in that aspect. We will look at wounds, what deformity is, where the infection could be and what to look out for. The temperature gradients of people's feet to their toes, which is very different. What skin colour there is and how it is important, especially in the Black and Afro-Caribbean status, where to look at edema and what it means when they have edema, what nail and skin growth looks like and what they should have with good circulation, and they should all have hair growth to their toes. When we look at circulation, we are looking at pulses initially, which is a hands-on examination. This is where we look at the dorsalis pedis, which is on top of the foot, palpated here on the diagram, and also the posterior tibialis pulse, which is located on the medial aspect of the heel, halfway between the medial malleolus and the calcaneum. This should be felt in a strong pulse format, and if you cannot feel it, this does not mean it is not there. So please be aware that other assessments are available. When we're looking at peripheral arterial disease, the areas to consider at risk or needing further investigation is when they are cold to touch, discoloured, purple or blue. There is intermittent claudication or cramping in the calf. There may be hairless toes or hairless feet, pallor in the skin, poor nail quality, and when we're looking at wounds, there is a delayed healing process. Please be very aware that peripheral arterial disease is highly prevalent in diabetic patients due to their lack of feeling or their neuropathy. They cannot feel the damage that is being done by the lack of circulation, like intermittent claudication or pain in the feet or a lack of walking. When we are assessing people's sensation in their feet when they have diabetes, this can be and is commonly greatly reduced when patients have problems with their feet. This is usually assessed using a 10-gram monofilament, which is a cost-effective instrument that should be used across all areas of foot assessments for diabetic complications in their feet. This is a 10-gram monofilament, which is applied at a 90-degree angle to the skin on the areas of the diagram shown here. And once the monofilament starts to bend, this exerts a certain amount of pressure. If this pressure is not felt on the person's skin, then this person has some sensation loss. This sensation loss can be patchy, but we do see sensation loss usually occurring at the distal part, which is the toes, and then can work down to the heel, and really poor cases of this can be a lack of sensation right up to below the knee. So it can be quite severe in some cases. When we're looking at deformity across diabetic feet, this is not actually cause of diabetes as such. This can occur in other patients without diabetes. However, there are some significant changes that we look for that can cause ulceration or put people at risk of ulceration. These can be clawing of the toes. This can be the bunions or hallux abductor valgus deformities. There is midfoot changes within the structures of the joints, causing limited joint mobility, which is a high area of pressure caused across the ball of the foot and the heel, and that's a cavoid foot type or high arch. This can also go the other way, where you get flat-footed postures, which increase pressures across the foot. In severe cases, we can see deformity across the foot from Charcot feet. This is another talk completely and has a lot more information on the website if you need it. So with these areas of high pressure and causes of concern or high risk areas, we can look at areas which cause calluses, which is a stress reaction to the skin to try and protect itself. However, these overgrow and in time start to cause higher areas of pressure, causing an increase in risk of ulceration. This is determined by looking at the type of callus it is, where it is, and if there is bleeding or extravasation into the callus. This is a high area of concern and needs to be referred immediately on finding this abnormality. So underneath this callus, we don't see this straight away. Once we get to debride this callus, very often we can see that there is underlying ulceration or a break in the skin, and this needs immediate action. Again, from a risk status of ulceration, increases the risk of bacterial infection and increases the risk of amputation. Our instant referral to the Diabetes Limb Salvage Service is warranted. When we're dealing with infection with people with diabetes, this can often be masked due to their lack of feeling or sensation in their feet. When we look at these areas of infection, this does need to be a face-to-face or hands-on assessment, and there are specific guidelines what to look out for. The common ones are erythema, swelling. Other areas where the patient might not feel this is where they say they cannot walk properly, they've got high blood sugars for no reason, they have leaking into their socks and shoes, and sometimes even if they have red lines going up their foot or into their leg. Signs of sepsis is remarkably reduced with these patients, so therefore that infection can cause sepsis very quickly, and they can end up within hospital settings within 24 to 48 hours, and this is a common occurrence. So please be aware of this issue and do not delay in referring through. With regards to the guidelines of antibiotic covers, please refer to the guidelines on the Leeds Health pathway and prescribe from these guidelines to assist us in empirically prescribing, so there is no delay in activating antibiotic cover and referring in immediately. So the risk status that I talked about earlier, where we look at low, moderate or high, there is clear descriptions about what these risk statuses are and what to do in the event that you find these. The moderate risk sector, which is where we find one of the areas about deformity, or you find neuropathy, or there is areas of concern for peripheral artery disease. This does need referring on, but it's not an immediate risk factor for the patient. However, if there are two risk factors involved in these areas, then they immediately go to the high risk factor. However, you might find that this is quite strange because we do know that they go immediately into the high risk factor if they have kidney failure, kidney replacement, or they've previously had an amputation or an ulceration in their feet. So please be mindful of this. You do not have to go through this risk factor if they've had any of these and they immediately go into the high risk factor, needing a referral to the foot protection service within the community setting. When to refer to the Diabetes Limb Salvage, this should be on finding any areas of ulceration on the feet. There should be an instant call if you're worried about infection or how to refer or what to do with the patient initially, and this is via the hot foot phone, which I'll come onto in a second. Any areas which are suspect of peripheral arterial disease, which we do find in the darker skin colours, which can be very difficult to spot and has been delays in the past. Any areas which have pain and there's no cause for the pain, please seek advice, and this may need instant or urgent referral to us. We do find, for example, that people can break their bones in their feet without actually knowing they've done it, and this needs urgent referral to us as well, without ulceration. A quick comment about advice and footwear. This is often overlooked through busy clinics, and this should be looked at through where people have deformity or calluses. And This can be a specialist area, but please be aware that footwear is important because patients do not feel when they are wrong for their feet. Common complications occur from slip-on shoes, shoes that don't fit their feet very well, too tight, too loose, and this can be difficult to spot, but usually comes about when you're looking at someone's foot for an assessment around their skin quality, rubs, previous blisters, sensation loss, clawing of the toes that do not fit footwear. Commonly, we use the soft and wide, deep toe boxes. Lace-ups are very important, and a good heel counter is a few of those aspects of good footwear. So this is a very common issue that we have with objects in people's socks, slippers, shoes. We've found glass, keys, bus passes. This one just shows an example where I think this is a bottle that was found in someone's toe box and has caused ulceration where they've rammed their foot into the shoe, causing their blistering and ulceration, which is unfortunately is a very common occurrence. Looking and expecting patients to do this is one thing that we do recommend when we're seeing patients in our settings. When considering education or advice to patients, when you've done this risk assessment and you've discovered whether they're low, medium or high, then there are specific leaflets for these that are available across the practices and can be given to patients with advice on who to contact and how to contact people. They are also available in different languages where available throughout Leeds and Bradford. With regards to active risk or issues around urgency, please ring the Hotfoot phone. This is available to any healthcare provider, patient or carer. This is a telephone number available 8 till 3, normally Monday to Friday, for immediate advice or urgent action needed, and same day provision of service. This is a backup to the email referral via the Leeds Health Pathway. This is found on your intranet, and please be aware that this has some specific advice about the antibiotic guidelines as well as the referral actions that you need to take. Before I finish, there's some useful links here regarding the assessment guides, Leeds Health Pathway, NICE guidelines and the leaflets. And thanks very much for watching.